This is Dr. Mary Chamberlain, and I am here with Mr. E. Thomas Starcher at the Centers for Disease Control and Prevention in Atlanta, Georgia. Today is Wednesday, September 27, 2017. I'm interviewing Mr. Starcher as part of the Oral History Project, The Early Years of AIDS, CDC's Response to an Historic Epidemic. Tom, welcome to the project. Do I have your permission to interview you and to record this interview?
You do.
Tom, your career as a CDC public health advisor spanned some 30 years, beginning in 1967. You were a senior public health advisor in CDC's Division of Sexually Transmitted Disease Services when the first Morbidity and Mortality Weekly Report on pneumocystis carinii pneumonia among homosexual men was published in June of 1981. A little less than 2 years later, you took a position in the expanding AIDS program and continued to work on HIV/AIDS in various capacities for 8 years. After your retirement in 2000, you've worked as a consultant for many of CDC's programs, including the HIV/AIDS program. But before we delve into the details of all of this, let's talk a little bit about your background. Can you tell us where you grew up and about your early family life?
I was born in Hawaii during World War II. My sister was born in Hawaii at the same time. My mom was born there back in the 1920s, and my dad was a police officer there for the Honolulu Police Department during that time. My mom used to relate stories of taking my sister and I to bomb shelters in full body bags, gas bags, because you couldn't fit a gas mask on a baby, and because there were concerns about gas warfare. My dad eventually took a position at the University of Maryland after finishing his master's degree at the University of Arkansas. He became a professor there, and I grew up in College Park, Maryland, up through my high school years. After graduation from high school, I attended a few universities, including where I graduated from, which was the University of Arizona. I had a major in zoology and a minor in chemistry.
So after college with this major in zoology, what were you aiming for career-wise?
I had actually been interested in becoming a veterinarian. I had been accepted to the University of Missouri in Columbia to their vet school. I needed one course in botany, which I didn't have, but found out that my wife was with child, and so I needed to get a job. And out of the blue, I received a letter from CDC asking me to come for an interview. I had not applied for a position, so I went on the University of Arizona campus. I met with Donald Malberg, who was a recruiter for CDC, and they offered me a position. They offered me 2 slots. One was in East St. Louis, and one was in Baltimore. As my wife and I had grown up in Maryland, I chose the Baltimore slot.
Oh gosh. So to this day, you have no idea how this unsolicited invitation came your way?
No, we were friends with a local CDCer in Tucson who was working in venereal disease control, and while he's never admitted it, I often suspected that he threw my name in the hopper for me to be interviewed.
Huh. So you were hired to work as a public health advisor, your first assignment being in Maryland. It would be helpful maybe if you could explain what a public health advisor, or PHA, is and how they fit into the overall scheme of CDC's professional staff.
Yeah, in 1948, the United States Public Health Service, their venereal disease control division, which was not at that time a part of CDC, had come up with the idea about new hires for their programs. These were to be college graduates. They would come in at the entry level, and their foci would be field work and contact epidemiology. Over time, those people would get exposed to various levels of public health work, and many went on to other programs. Probably the biggest success story was Bill Watson, who came in as a public health advisor, who became deputy director for CDC.
So you started in Baltimore, but I believe over the next 10 years or so moved around quite a bit, working with venereal disease programs. Was that the norm, and why? Why were PHAs moved around?
Well, a lot of them were moved around based upon their experience and where they could offer more help in a particular area. For example, when I was in Baltimore, the first year as an employee, you were required to write 4 narratives, quarterly reports. One of those I did was on the Epidemic Intelligence Service. I was fascinated with the concept, with what Dr. Alex Langmuir had put together. I really wanted to become an EIS officer, but I didn't have the qualifications. But anyway, that was one of my narratives. Also, while I was in Baltimore, I was involved in a pilot study looking at gonorrhea culture media for women. We didn't have at the time a good way of diagnosing gonorrhea in women. You couldn't do just a smear like you could in men. And so anyway, after 3 years there working in Baltimore, I was transferred to Altoona, Pennsylvania. And similar to what I thought was fascinating about EIS, they had me working across the board. I was handling 16 counties. I was handling it for immunization programs, for tuberculosis programs, and for STD programs, which I really liked the concept because when you went into a doctor's office, you could talk to the doctor about all of the patients, his tuberculosis patients, STD patients, about immunization levels, as opposed to having 3 different people coming through the door and taking up the doctor's time. So I enjoyed that. It was a great experience. But in April of 1972, Congress appropriated $24 million to set up a national gonorrhea screening program for women. And so they sent me, because of my background in the pilot project in Baltimore, to Springfield, Illinois, where I was the deputy director for the STD program and helped in setting up a statewide gonorrhea culturing program for women. From there, a position came open in South Dakota for the director of the STD control program, and I applied for that and was accepted and did 3 years of work there, was involved in doing some research looking at gonorrhea culture media and how well it transported in sub-zero temperatures, et cetera.
Oh, because it was cold there.
Yes, very cold. And so I wrote narratives on that. And I got a call from CDC, from the Operations Research Branch in Atlanta, and they wanted me to come work in that branch on some research projects. So I accepted that position and came to Atlanta in 1978.
I'm impressed that there was a real research component to a lot of the work that you were doing, because I think people sometimes think of people working in venereal disease programs as just contact tracing, going out, finding people, interviewing people, but there was a real research component to the work that you did.
There was, and I enjoyed that aspect of it, and I enjoyed working in the Operations Research Branch. I worked on a large gonorrhea research project out of Des Moines, Iowa. And I was fascinated with the research. And it probably goes back to my interest in veterinary medicine and doing more than just the contact tracing and all, which is extremely important. It gave me exposure to lots of different levels of public health, as a lot of the people that are working as public health advisors today get. The public health advisor today, the public health associate program, is basically the iteration of that. And these folks are coming in as college graduates, but they're not coming through just the STD program. They're coming through all different kinds of programs.
Before we talk about your work experience in Atlanta, I just wanted to pick up on something that you mentioned, that you would be out visiting doctors' offices and talking with them about cases of not just STDs, but TB, immunization issues. How receptive were doctors to having people from the health department show up on their doorstep? Was this just kind of a very accepted way of doing business?
I think there are always challenges to taking up a doctor's time. So it's a matter of being able to talk about important issues. Of course, STDs are reportable, tuberculosis is reportable. So when you're dealing with those kinds of things, a doctor is under some obligation to be sure that they're reporting them. And you're actually following up on reported cases in most instances.
I see, and making sure that they've had
adequate
kind
treatment.
of adequate treatment and follow-up.
And follow-up. And I was involved in taking TB Today at CDC to gain some understanding of tuberculosis, a very complex disease, fascinating disease.
Oh, gosh. So you said it was, I think, May 1978. You arrive in Atlanta, your first headquarters job, and you were there for some 5 years. And I think this coincided at a point in time when there was a real effort to implement changes on a national level in STD control methodologies. And what was that all about? Why the need for change?
Well, initially when we started in Baltimore and a lot of the follow-up, the focus in STDs was largely on syphilis. And it expanded because we realized that gonorrhea really caused a lot of problems, especially for women, involved also looking at chlamydia, other STDs. So there was an expansion in terms of just looking at STDs from a different vantage point. The Gonorrhea Project in Des Moines was a really important project. Based upon our findings there, we kind of changed how contact tracing is done nationally. We found out, for example, that rather than just interviewing males who are symptomatic for a 30-day period to try and find out about their sexual partners, that if you cut it back to 14 days, cut the work level in half, you would find over 90% of infected contacts and wouldn't have to go through the extensive work for little reward for the extra 2 weeks. So a lot of came from that project. We got published on it. It was a very rewarding experience.
Okay. So during this time, when you're in CDC's STD division, did you start to hear in the course of doing your work, did you start to hear anything about unusual occurrence of diseases in homosexual men prior to the MMWR publication in June of 1981? Was there stuff kind of, not rumors or going on in either with patients that you were, or physicians? I was just curious if there was kind of a drumbeat.
I don't remember anything like that at the time. I was working for Jim Curran at the time, who was the chief of the Operations Research Branch in the old venereal disease control program in the Center for Prevention Services. And I certainly knew when he got tapped in June of 1981 to start looking into the report and the findings from that MMWR about pneumocystis carinii pneumonia showing up in otherwise healthy gay men, previously healthy gay men. So I knew about it at the time. I was not aware of anything prior to that.
Interesting. So Jim gets tapped to head up this new, what ultimately was called a task force.
Yes.
And I think several other STD colleagues were also brought along to work on this task force. It was a kind of an informal thing.
Yeah, I remember because I really enjoyed working for Jim, just an absolutely great guy. I certainly remember when he ended up leaving, and there were a number of people in the venereal disease control program who went with him at the time, Harold Jaffe being one, Bill Darrow being one, Mary Guinan being one. There were just a number of people who went with him at the time, so I knew what was going on at that time. I got a new boss.
That sounds like a big chunk of people sort of leaving.
It was, and key people, very key people.
So that's 81, and almost 2 years later, in April of 1983, you moved over to work in CDC's National Center for Infectious Diseases to work on the AIDS program. I can sort of guess how that came about, but why don't you tell us?
Well, I got an invitation from Jim from Jim Curran to come over to help set up national surveillance for AIDS case reporting. Dr. Jim Allen, who was coming from the hospital infections program, was going to be heading it up, and Jim wanted me to come over to see if I could help Dr. Allen. I was a little hesitant at the time because most of the public health advisors at CDC were in the Center for Prevention Services. There were very few in the Center for Infectious Diseases, and I was very concerned about how well they would be received in CID. I contacted Frank Miller, who was a good friend who worked in the STD program with me. We actually used to play chess over the lunch hour together, and I think he was the first EEO officer for CDC. But he was in CID, and I contacted him and asked what his thoughts were about how receptive CID would be to public health advisors. And he told me that he thought I would be well received. And in retrospect, after I accepted Dr. Kern's invitation, it was a great move. It was an absolutely great move. I found Dr. Dowdle, the director for the CID, and Dr. John Bennett, the deputy director for CID, to be two of the finest, most professional, most competent individuals that I had a chance to work with during my 30-plus year career. Both very supportive of public health work, very supportive of public health advisors. It was a great move, and it was good advice by Frank.
Well, I do want to spend now some time talking with you about AIDS case surveillance, as that was certainly your focus for the next 5 years or so. And in fact, you led the AIDS surveillance branch for a period of time. Why don't we start from your arrival? So you arrive in April 1983, so it's not quite 2 years after those first cases had been written up in the MMWR. So can you tell us, when you arrived on the scene, what was the status of AIDS case surveillance and reporting at the time on a national level?
Well, at the time I arrived in April of '83, there had been just over 1,000 cases reported to CDC. One of the difficulties was we didn't know what actually caused AIDS at the time. So we went on a clinical definition that had been largely developed by Dr. Richard Selleck. And cases had to conform to that clinical definition to be accepted as an AIDS case. One of the big problems that kind of got out of the way that CDC does business was a lot of the reports were coming directly to CDC, and they were bypassing health departments. And CDC has traditionally relied on health departments as being the point where cases get reported to, and then from those health departments to CDC. So one of the first things that we did in setting up a national program was we hired a nosologist who was already at CDC. Her name was Mary Catherine Rogers, and her chore was to review the cases to be sure that they met the strict clinical definition so that they could be counted as a case. Many of the reports that we received did not meet that clinical definition, and so were not counted as AIDS cases. And then we set up an announcement for cooperative agreements for many major city health departments, included New York, Baltimore, Washington, D.C., Chicago, Los Angeles, San Francisco. And we made awards to them for setting up surveillance. And the goal was to have cases reported by doctors and clinics through those health departments onto CDC. So we got back into the pattern of using the health departments out there as the true partners that they are for CDC. And it was interesting. We had one application that came in that I will not mention the name of it, but the application came in and said that they were going to identify these individuals and then follow them to see where they went and with whom they met.
Oh, literally? Like
yes,
stalking them?
Yes. And
Oh,
we sent the application back. It was an important, a large city, urban area. We sent it back and asked them to resubmit it more along the lines of traditional CDC-type surveillance, which they did, and they became a very important partner.
Now, I know, having myself been posted in New York City as an EIS officer, 82 to 84, New York City had been the recipient of the first CDC cooperative agreement in, I think it was January of 83, so right before you came.
Yes.
And it was really sort of a pilot to at that time, most cases were being hospitalized, and we used a hospital-based system of surveillance, which would be pretty good, and we actually did demonstrate, was very good at capturing cases, because that's without treatment and a test, most people ended up in a hospital, sadly. So I was curious, a couple things. Do you remember how much money you had to distribute? Because the cooperative agreement is the funding mechanism to get the money from headquarters out to these health departments. And I'm just kind of curious, how much money were...
I do not remember.
I can't imagine it was a lot. But
No, we didn't have a lot of money, and we were doing it sequentially. I mean, we started out with some urban areas, and then we expanded over time where we got to state health departments, other urban areas. But I don't remember how much money was available.
And then your comment or your story about how one of your health department applicants proposed to go about doing surveillance, I think raises the question of, at the start, had CDC sort of developed, maybe with the help of health departments, sort of agreed on procedures about how to do surveillance, or certainly suggested methods to use in identifying and getting cases reported?
We certainly used information and feedback from the health departments in developing the policies and procedures for doing active case surveillance. And they were instrumental in being part of that. But we came up with guidelines on how to do active surveillance, and we would continue to refine them over time as we would find new things that would be helpful in identifying cases. So we developed them, and that was part of what we did in the surveillance section to help guide them. And also, we developed guidelines for them in doing their applications for cooperative agreements and all. So it gave them some insight as to the kinds of things we were looking for.
It's probably good for us to distinguish between the two traditional types of surveillance, active versus passive. And you've mentioned that health departments were being encouraged to implement active surveillance.
Yes, where they were actually going out and looking for cases, beating the bushes, reviewing death certificates, doing all kinds of things, looking at laboratory reports, hospital-based reporting, et cetera, to try and find those cases. Up until April of '83, those were largely passive surveillance. People in the doctors and clinics would find cases, and they would voluntarily report them to CDC, et cetera. But with the active surveillance, we were actually paying them to beat the bushes to find the cases.
Yeah, because just dating back to your experiences in various state-based programs as a public health advisor, you knew very well that reporting fatigue is a real phenomenon. Doctors,
yes.
Nurses in hospitals, people are busy, and the idea of filling out a case report form and then submitting that to a health department, and then oftentimes the health department coming back and asking you a few questions, that's time consuming. So.
Yes. So we were actually, through the cooperative agreement, providing them funding to set up active surveillance. They would hire staff to go out and beat the bushes and submit case report forms, again, through the health departments onto CDC.
How did health departments initially transmit case reports to CDC? Were these hard copies of case report forms that were mailed to CDC?
They were hard copy report forms, and they included a lot of personal identifiers, patient names, patient addresses, patient phone numbers, a lot of personal identifier information. And shortly after we got started with the active surveillance program, we met with Dr. David Sencer, former CDC director, and at the time he was Commissioner of Health for New York City. And he suggested strongly that we look at what was called a Soundex system, an alphanumeric algorithm that took the patient's surname, the first initial of the surname, followed by 3 numbers that were based upon the consonants that got in the surname that got a numerical value, and that was a unique identifier for the individual. And coupled with the patient's date of birth, it was a very unique identifier. While each Soundex can represent many different people.
Yeah.
The Soundex itself, only one person will have one Soundex code for them. And so we switched over to the Soundex system based upon his recommendation and our finding out that it would really work. It would allow us to be able to communicate back with reporting sources because we had that information. We didn't need the patient's name, didn't need the address, didn't need the personal identifiers. In fact, we began converting all the previously reported cases to a Soundex code, and we began the process of deleting all the personal identifiers. And Tom Leonard, who was one of the public health advisors working there, was given the task of taking a razor blade and cutting out all of the personal identifiers, which he did, and it was extremely valuable. Confidentiality was the name of the game in terms of continuing to get reports. If there had been any breaches of confidentiality, it would have been very, very hard on us for us to be able to continue to do active surveillance. And we had set up a lot of guidelines around confidentiality and how we handle case reports, locked file cabinets, policies and procedures, who could have access to the files, et cetera. So,
and these were recommendations or policies and procedures that were implemented in Atlanta, but were also part of the guidance that you would that you would send out to health departments.
Absolutely. Absolutely, because again, if a health department, if there were breaches of confidentiality in the field, it would hurt their ability to do active surveillance.
Because at this point in time, as you say, there was a lot of concerns about confidentiality in affected communities. Because not only were personal identifiers being collected, but some of the behavioral risk information, the risk factors, if you will, that was an important part of the case report form. What was the risk exposures for individual cases, be it men having sex with men or intravenous drug use? These were illegal activities. People were very vocal, as I recall.
They were, and I think justifiably so. I mean, we got inquiries from attorneys. We got one inquiry that went to Dr. Fahey, the director of CDC, where one congressman was asking for the names of AIDS patients, which of course the congressman never got. But we were very concerned about whether or not lawsuits would be filed to get access to the information, et cetera. And in addition to what we had done around the confidentiality guidelines and all, Dr. Fahey was very supportive of a request to use the 308D, Assurance of Confidentiality of the Public Health Service Act, which was the highest statutory protection available to protect those data. And we applied for and got that assurance, which made us feel good about not being able to or have to turn over that information for whatever reason.
Gosh, I mean, a congressman requesting a case list.
Yes.
For whatever reason.
Yes.
Well, was it unusual to get an assurance of confidentiality?
It was not given out a lot, and it was what we were advised would offer us the highest statutory protection available, and so we applied for it. And Dr. Fahey was very supportive of it. We were able to get it, and it afforded us great protection for our case reports.
Was that something that you had to work with the CDC attorneys with?
Did work with the CDC attorneys on, yes.
Yeah.
They were great, just absolutely great. Gene Matthews and Verlin Nezel were extremely supportive of what we were doing with the AIDS surveillance program and AIDS in general.
And obviously you must have had contact with Dr. Fahey, the director of CDC. I mean, it was at that level.
I actually got to meet with Dr. Fahey, which was a real pleasure. He's just one great public health person.
If we going back, so that was obviously an important, a really important step in providing, as you say, some reassurance to to affected individuals, how seriously the agency took and instructed health departments to take confidentiality, because health departments, of course, were collecting names locally.
Yes.
And which was important for them to have as treatments and things like that became available. Ultimately, you've got these cooperative agreements out to what? Ultimately, all 50 states,
Yes.
big cities?
Yes, and territories.
Territories.
Yes.
So that's a big deal. How did CDC headquarters try and assess how well programs were doing in adhering to the procedures, not just about confidentiality, but about how surveillance was undertaken? Were there any sorts of evaluations or assessments made?
There were, and I'll just back up for 1 minute. One of the things that we were apprised of early on was the Government Accounting Office was sending an auditor to come take a look at what we were doing with AIDS case reporting and the AIDS program in general. And it was at that time that Tom Leonard had just finished deleting all of the all of the personal identifiers because we were afraid we were going to be asked to show case reports to the auditor.
Oh, God.
And the auditor showed up and came into my office and shut the door and sat down in front of my desk, and he said, your name has come up on the floor of Congress, and you have been accused of hiding AIDS cases.
You personally, Tom Starcher?
Yes, and I was certainly taken aback and asked what was the genesis of that. And we had been putting out weekly surveillance data sheets that listed all of our case tallies, broke cases down in general by risk factors, by age, by gender, by type of disease, et cetera. And we'd been putting those out for some time. Well, it turns out that the focus that he had was that we had a footnote that listed cases that had been reported internationally, and we didn't count those cases as part of our tally. And part of the reason we didn't count them was we couldn't be sure that they met the strict case definition. Often we did not have a way to get back to those international reporting sources, et cetera. So we tallied them just as a footnote. And so the question had come up why those cases weren't being counted in our overall case count. And so once we resolved that, I could breathe a little easier.
So you weren't hauled off to federal prison.
And one of the things that I did as a surveillance section chief was I would frequently talk to other people about doing surveillance. And one young man was from the Uganda Ministry of Health that was visiting Atlanta, and we sat down to talk. I had never had the opportunity to work in Africa, so I didn't have an appreciation for his healthcare system and what it involved and all. So I tried to take our surveillance system and distill it down to what I thought would be the simplest steps that he might employ. For example, I asked him if they took a look at, for example, in hospital cases, did they come from one particular area of the country, a particular village or whatever, to try and get an assessment of whether more cases were occurring in one area or the other. And the young man said to me after I finished, he said, "But we don't have pencils and paper."
Oh,
and
gosh.
it just floored me.
Gosh.
But it also bolstered my feelings about why maybe not accepting international cases as part of our case count was probably pretty valid.
Good idea.
When we started beefing up with all of these health departments and all, we brought in other public health advisors, brought in Debbie Deppie from the VD Control Program in North Carolina, brought in Jeff Eford from Louisiana VD Control Program. And these people assisted us in going out to states and cooperative agreement recipients and reviewing what they were doing in surveillance and all. And in fact, we assigned Debbie to New York City for several weeks to assist them with their surveillance efforts. we also formed a team. It basically was formed by Dr. Curran, that a team of folks from the AIDS program would do site visits. And it included somebody from surveillance, Jeff or Debbie or me, one of the doctors, actual physician, and somebody from education to talk about community education and patient identification. And we would go out and do site visits and then meet with the staff in the cooperative agreement areas to go over what they were doing, to answer questions, to give them guidance, make suggestions, get feedback from them on what we could be doing better, et cetera. So it was a two-way street, and I think it worked out very well. And in terms of the evaluation, about 1985, we did an evaluation of case reporting, the completeness of case reporting. And we looked at 4 major metropolitan areas, New York, Washington, D.C., Boston, and Chicago. Those 4 areas at the time had reported 38% of all of our cases. And we set up a protocol and used the Chandrasekhar-Deming Mathematica formula, which is basically a capture-recapture system. And we used death certificates to compare against the reported cases in those areas. And Dr. Ann Hardy, who was an EIS officer in the surveillance and evaluation branch, oversaw the project. And the results showed that we were getting 89% of all AIDS cases reported nationally in those 4 areas. The range was from 83% to 100% for the 4 areas, which was pretty remarkable given that you look at other reportable diseases and none of them really came very close to an 89%. I think tuberculosis was somewhere around 63%. Hepatitis a little bit lower in that area, salmonellosis a little lower. So we felt good about that. Dr. Hardy reported those findings at the International AIDS Conference in Paris in 1986.
I know you were very instrumental in writing the protocol for that study. And I just want to clarify, to make this a valid method of, if you will, of evaluating the existing case report surveillance system in these cities, they could not have been using death certificates as a way to find cases. Is that correct?
During the time period that we were doing the project, that's right. They could not use those death certificates. It was done after the fact, after the 3-month period in which we were assessing case reports.
Right. So it was an alternative method to sort of check, as you say, to check on completeness.
Yes. And I had the opportunity to run the protocol by Steve Thacker, Dr. Steve Thacker, who was the director for the epidemiology program office, and he reviewed the protocol and basically blessed it. So we felt we were on solid ground with the protocol. And
Steve was certainly considered a surveillance guru at CDC.
He was.
Absolutely. Your comment about the remarkable level of completeness compared to other diseases, and I think probably holds to this day, but in fairness, I think, and I like your comment on this, there was an awful lot of money being poured into AIDS surveillance at the time and continues to this day.
Absolutely.
Because most of these other diseases, it's they're relying on passive methods.
Some do. Some have active programs. I mean, the STD program, and I think tuberculosis was active.
Okay.
Because I was in Pennsylvania working on tuberculosis. I mean, I had 2 register clerks, and we were actively following up and visiting doctors who saw anthracosilicotics and TB patients and whatever to get that information. But you're absolutely right. I mean, public health surveillance is so dependent upon the funding.
It is. It is. I want to pick up get a little bit more information on a comment that you made earlier. You were talking about the generation of these. They were initially weekly, and I think then became monthly reports of AIDS statistics. So when you first arrived, as you pointed out, you're dealing with hard copies of case report forms that are being mailed in by health departments. Mary Catherine Noah, the nosologist, is carefully reviewing them. And I know Richard Selleck also had a big role in looking over case report forms to determine if these cases are complete. There's oftentimes many questions having to go back to the health department to clarify if indeed certain criteria had been met. And then you generate a weekly report. You know, every week this is the latest. So this is largely pre-computer. How are you generating these weekly reports?
Well, actually, Dr. Meade Morgan, who was the director for the statistics and data management branch for Jim Curran's program, was instrumental in just getting everything working in terms of the computers and all. He also was very instrumental in getting out a software program on Soundex conversions to all of the health departments so that they could just plug in a name and it would automatically kick out the Soundex, and they didn't have to figure out all of the number combinations, et cetera, for the consonants. He was absolutely brilliant. And he was the one that fast-tracked our getting these reports together on a weekly basis. And the reports generated tremendous numbers of questions. We would get calls from health departments, from the public, from newspapers, from the media, from attorneys, from everybody under the sun, each week asking for those data. They followed them as religiously as we did.
But this is pre-internet. I mean, you're not posting them online. How are they being distributed?
We were sending out the
in the mail.
In the mail, yes, and it was available for people calling in because they would call in. I mean, every week I was getting a call from Randy Schultz from the San Francisco Chronicle, who of course went on to write "And the Band Played On" about the early days of the AIDS epidemic. But he would religiously call weekly asking for the latest numbers, ask for breakdown for risk factors, et cetera. So we fielded a tremendous number of calls at that time.
Now, in your time on surveillance, were you able to witness the transition to electronic reporting, or did that happen after you left?
I think it largely happened after I left.
Okay. And another innovation, again, as you're saying, this tremendous interest in access to the data. Ultimately, CDC established, with Meade Morgan's guidance and leadership, what was called the public use data set.
Yes.
There was such a demand for the data that a subset of the actual raw data, I believe, was loaded up and made available.
It was made available, and it was constructed in such a way that there were no small cell data items, because in small cells, there's a possibility that you could actually identify an individual. If you knew an individual's race, for example, who may be gay and is also hemophiliac, in a state where they may have only one individual of that race who's a hemophiliac, they would say, well, I didn't know that so-and-so was gay. And so we were very careful about small cell data and the release of that information. But it really did generate tremendous amount of interest. Dr. Alex Langmuir, who is the founder of the EIS program, actually came down from Buzzards Bay, Massachusetts, from his retirement home, and I got to meet him, and he wanted to talk about AIDS case surveillance. At the time, we were doubling AIDS cases every 6 months, and he was very interested in the whole trends. So he was one of my public health heroes, and I actually got to meet him, even though I was never an EIS officer.
But should have been. But should have been.
Oh, thanks.
Exciting times. You also, another aspect that you alluded to was staffing. So when you first came over, Jim Allen was the head of the surveillance branch. It was probably a branch then. And you and Mary Catherine. And then you started bringing in more public health advisors. Can you give us a sense of what you started from and how fast and how much you grew
Well,
by?
as the cooperative agreements grew, we brought on the 2 individuals in surveillance, but Jim Curran brought on a number of other public health advisors in other areas that were not involved in surveillance. People like Harold Van Patten, and I mentioned before Tom Leonard, and Wilman Rushing, who was Jim Curran's deputy, was a public health advisor. Larry Zyla had already been here before. He had come from the STD program from before. He worked in STDs, and he was in the program. Dave Colley, John Narkunis, Ron Sanders. The program just burgeoned up. But I mean, the program was just getting huge. I mean, our offices, when I started, we were in Building 6 in a long corridor of offices that used to house animals. The doors had windows in them. The light switch was on the corridor wall so that people could flip on the switch and look in the office and see what was going on.
Because these rooms were where they had cages for the chimps for,
yes.
I think, hepatitis
well,
study?
I'm not sure if it was chimps, but there were definitely animals in
Large
there.
animals.
Yeah, the baseboards were beveled concrete so you could hose them down, etc. And so when I started, I had an office of my own, but as we got larger, it was necessary to double up. And I think we had, actually in one room, we had 5 surveillance people at one time. But the program was just growing. I mean, because of the amount of disease, it just kept going and going. And so we started bringing on lots and lots of additional people.
And along also with surveillance, AIDS case surveillance growing and growing, this whole new, I don't know if the right word is spin-off, eventually occurred, which was once there was a test for HIV, there was an interest in determining the prevalence of HIV.
Yes.
And so this, what was called family of seroprevalence studies came about in various populations to try and look at just how much AIDS or HIV virus was in these various populations. And you were there at the time, because isn't that when seroprevalence and surveillance split off?
Yes, and Barbara Kilborn, who was a nurse, I think was working on the blood side of things. But yeah, when I was there, pretty much just dealt with AIDS case reporting, cases that met the AIDS case definition. I do remember working with Ladine Newton in the CDC policy office, and we were developing at the time ICD-9 codes for the spectrum of disease, and I remember working with her, but in terms of my own involvement, I really never got much involved in the HIV seroprevalence areas.
Right, yes, because there actually had to be a physical splitting of staff, and I think that was the time that then you ended up heading up the surveillance program for a period of time.
The surveillance section, yes.
Yeah, that section when that flipped. So the program is growing. Cases of AIDS are growing. The demands for data and information growing. What was the work environment like? It sounds like it could have been pretty much of a pressure cooker.
It was a pressure cooker, and it was a pressure cooker in the sense that, I mean, I remember arriving at 4 and 5 in the morning to start work and not being alone. There would be other people there and putting in long, long hours. But it was necessary in terms of trying to keep up with things. And a lot of the pressures were external pressures, lots of inquiries from Congress about what was going on, lots of interest from the media. It was a pressure cooker.
Oftentimes, people, I think, don't have an appreciation for the foundational nature of surveillance to public health, that it really is the foundation from which a lot of other special studies or prevention activities are born. Did you have a sense that surveillance was being appreciated at the time, that that it wasn't just considered sort of a poor stepchild for the whole AIDS program, or?
You know, from my own perspective, when Jim Curran approached me in April of 1983 about coming over to work on surveillance, I really had a lot of second thoughts about surveillance. But I will tell you that after being involved in surveillance for the time that I was, it was one of the most fascinating and important parts of my work in public health. And in retirement, I have continued to use surveillance in many ways. I've done a lot of volunteer work for domestic violence prevention. And when I would do the work with some of the organizations, they weren't looking at surveillance, and they didn't have good data to make strong arguments for the positions that they wanted to take. And being able to get those data and get those organizations looking towards data made all the difference in the world in terms of funding levels and all. I mean, one of my favorite people at CDC was Dr. Ward Cates, who I had the chance to work with in STDs and also in AIDS. And also, he was a great tennis player, and we had many battles on the court. Just an all-around great guy. And he used to have this motto about see one, do one, teach one. And I took his motto to heart. And in retirement, working with some of these organizations, I had the opportunity to work with a director for a domestic violence prevention organization. And I wrote the grants for her the first year. I made her watch. The next year, I made her write the grants, and I watched. And the next year, she went to the state capitol and she taught grant writing for all of the organizations statewide. And part of the foundation was based on surveillance, being sure that people were collecting those data. I learned to appreciate surveillance. I really did. It is a critical part of public health. You can't do public health, I don't believe, without surveillance.
So long hours, pressure cooker, but what was the environment like?
The camaraderie was great. I give Jim Curran all the kudos in the world for the staff that he brought together and for how he handled everything. And you know, he surrounded himself with just some dynamite people. I mean, I mentioned Harold Jaffe before. Harold went on to become a center director. He went on to become the associate director for science for CDC. Ken Castro, who was an EIS officer, went on to become the division director for diabetes translation. John Ward, who was an EIS officer, went on to become the director for viral hepatitis. I mean, Jim just turned out great people in terms of his own philosophy, and they became great public health people in their own right. And there were many, many other people. But to me, it was one of the greatest environments, even though it was pressure-laden. It was one of the best environments I worked in my career.
Well, I want to switch gears a little bit because you did move on from AIDS surveillance in June of '88 to Washington, D.C. A totally different environment and a very different job working out of the Office of the Assistant Secretary of Health. Something called, I think, the National AIDS Program Office?
You know, the Assistant Secretary for Health had created the staff office called the National AIDS Program Office. The director was Peter Fissinger. Dr. Peter Fissinger was the former deputy director for the National Cancer Institute at NIH. And the concept was that the burgeoning AIDS problem was affecting all of the PHS agencies to the degree that they wanted to get a better handle on what was going on. And they created this office, and there were desk officers for each of the PHS agencies. So I was fortunate enough to be selected.
Did you apply, or were you volunteered?
I actually applied.
You did? Okay.
I applied for it and was interviewed by Dr. Fissinger and was selected. And I had counterparts from NIH, from HRSA, from FDA, from all the PHS agencies. And we were the focal point for our own agency in terms of bidirectional sharing of information. Information would come from CDC through the CDC desk officer there, and information from Washington would filter through me and back to CDC. Had a lot of responsibilities, including writing letters for the Surgeon General, writing letters for Congress, writing letters for the White House, just a lot of involvement around AIDS-related activities. Also got to play an instrumental role in the PHS task force for AIDS. They were in the process of developing a partner referral program for sex partners of HIV patients, and they would not entertain looking at IV drug use partners because IV drug use was an illicit activity and they didn't want to have that on their plate. So they were only looking at developing a policy around basically contact sharing, finding for HIV patients. And I knew Dr. Kathleen Toomey from many years before. She was an EIS officer in Alaska. She was also the director for the Venereal Disease Control Division, or I think STD Control Division at the time she was there. And she had gathered some data from Baltimore looking at contact tracing for IV drug-using partners. And the data were overwhelming in terms of being supportive of the importance of doing that. And it brought her up from Atlanta, and she presented to the PHS task force. And she did a great job and sold them on it. And so the PHS policy that came out included both sex partners and IV drug-using partners. And I consider that one of the highlights of my time in Washington while I was there.
So the public health, so I just want to get a little, make sure I'm clear on there were lots of sort of entities, it sounds like, that were that had been formed up there. So there's the National AIDS Program Office.
Yes.
Which is you and desk officers from the other PHS agencies.
We were a staff office to the assistant secretary.
Okay. And then the Public Health Service Task Force, just give me a little bit of background on
those were more senior people from the agencies themselves. I mean, one clear example is Dr. Tony Fauci from NIH.
Oh, so he's a member. Okay.
He was a member, a very, very key member. Dick Reisberg, who was the PHS attorney, was a member. So it included senior people from the various agencies and all that were putting together policies.
We're setting the policy.
Yes.
Okay. Okay. Gosh. And so obviously this was a big issue, this whole idea of the guidance that was going to come out about
Absolutely.
Contact tracing. Who was the Surgeon General at the time?
C. Everett Koop.
So Surgeon General Koop, there were other really hot button issues that were going on in Washington in that time period, that some of them that Dr. Koop was involved in. Were those things that you and your colleagues also had to help and support Dr. Cooper?
If it was AIDS related, yes. If it was not AIDS related, we weren't really involved.
So this is when he put out this
the national brochure.
National brochure,
yes.
Understanding AIDS.
Yes.
And can you give us some behind the scenes about what it took to get that?
Well, I mean, it was an extraordinary effort. I mean, you think about a mailing to every household in the United States. I mean, it was extraordinary. And Dr. Koop was very supportive. You know, initially I was concerned, but he was very supportive of working on AIDS. And so it was a pleasure to work with him. I didn't work that closely with him, and I didn't have private meetings with him, but word would filter down about what he needed or whatever, and I would try to be supportive for him.
Yeah, that was that was somewhat controversial, sending out that brochure, as you said, to every household in America, because
Yes.
it contained some fairly direct text about
Yes.
ways in which people acquired AIDS and ways to prevent acquisition of the HIV virus.
Yes.
Traditionally, there's sometimes rivalries between the various public health service agencies, CDC, NIH, FDA, whatever.
Yes.
They're mixing in the pot because a lot of these issues really crossed over, had facets that crossed over into multiple agencies. It wouldn't be just a CDC or just an NIH issue, for example. What was the camaraderie like up there with your desk officers?
I thought it was actually quite good, and it wasn't so much competition at that level. I mean, I remember working with Dr. Valerie Setlow, who was from NIH. And we had a great collegial relationship in terms of working together. And it gave us an opportunity to see what other agencies were doing, how we could fit into what they were doing, how they could fit into what we were doing. So I very much enjoyed my 3 years or so with the National AIDS Program Office.
Moving from Atlanta to Washington, in Atlanta you were operating, I'm guessing, mostly as a technical person. Obviously with some in-house or external minefields to have to be dealt with. But moving to Washington, which is a hotbed of political and the policy making and all of that, was that a hard transition? And
it wasn't a hard transition. I had grown up in the area, and so I knew Washington pretty well. And I tried to stay away from the politics in general. The position of CDC desk officer opened my eyes to a lot of other things that were going on with regard to HIV and AIDS at CDC that I wasn't exposed to while just working on surveillance. So it was very personally rewarding to see what else was going on, to learn what else the agency was doing. So it wasn't a hard transition for me. I thoroughly enjoyed it. I actually would like to have stayed in Washington, but the better half wanted to come back to Atlanta. So,
so when you came back to Atlanta, it was in a different position. You didn't come back to AIDS.
I came back as the deputy director for the Division of Reproductive Health. The predecessor there, Pat McConnon, who I'd known from STD days, who was the deputy director, was taking a position with the Carter Center, and it had opened up that position. And so I was selected to be the deputy director there, which was also a very rewarding position. I thoroughly enjoyed my days with reproductive health. And ultimately ended up, after about 8 or 9 years there, being asked to come over to the director's office to work with Dr. Claire Broom on the National Electronic Disease Surveillance System. And I can thank Meade Morgan for throwing my name in the hopper on that one. But it really came full circle in terms of my surveillance activities and all, and then working with Dr. Broom on the National Electronic Disease Surveillance System. So that was great.
You've alluded to this a couple of times, but I want to ask you directly. Working as you did in the early days of the AIDS epidemic, you were part of something that really changed history in the course of public health, I think. How did that affect you personally and professionally?
Oh, I really have to thank Jim Curran for bringing me over. I guess I'd led somewhat of a sheltered life up until that time, and I found it just critically important in terms of the work that I was doing, while important in the STD program, to be dealing with a disease that was so devastating in terms of what it was doing to young people, especially talented people, and being at the forefront of working on that disease and trying to get a better understanding. I just found it very personally rewarding, one of the highlights of my career.
Are there things that you look back and think that maybe CDC could have done better, a better job of?
I don't think CDC necessarily could have done a better job. Early on, we just weren't getting the kinds of publicity and support that was really necessary to get the word out about what was going on with AIDS and all. I think that was probably one of the most disappointing things for me. I couldn't see how anybody could have worked harder than the group that was working in the early days of AIDS. I just don't see how that could have happened. And the support within the agency was phenomenal, from Dr. Faggy to Dr. Dowdle to Dr. Bennett to the attorneys. It was just phenomenal in terms of support. I couldn't have personally, from my perspective, asked for more support than I got.
I know when you talked about after the initial MMWR came out and this ad hoc task force was formed and siphoned off a lot of people, you said very high quality people from the division of STD to start to work on this new disease. There was obviously no funding. I mean, there was no line item for this, and then the area that you worked in, surveillance, you described for us very well how that grew. Do you remember what it was that kind of turned the tide, that all of a sudden things started to change, AIDS became recognized as an important public health problem and funding opened up? I don't know if it was one event or just over time. Do you have a sense of what it was that...
Well, I mean, a lot of people will say that the issue with Rock Hudson was maybe a big turning point in terms of getting the publicity out there about the importance of this devastating disease. I think the media was very important in terms of continuing to highlight what was going on and all, in terms of maybe getting people's attention. But a lot of people will say maybe that was the Rock Hudson thing that kind of got more publicity going on.
And started things turning around.
And then of course, when Dr. Coop did the household mailing and all, and that started getting a lot more out there. Well,
are there any closing thoughts? Is there anything you'd like to add that we haven't covered?
In retrospect, for me personally, I was devastated when I didn't get to go to veterinary school. And I never even conceived of a career in public health. But when I look back on my life, it was the most rewarding career one could ever ask for.
Well, Tom, we're certainly glad that public health found you and that you gave it a try. This has been very interesting talking to you about the origins of surveillance, which, as we said, was so foundational to everything else that grew up around it at the time. So thank you so much for joining us in this conversation. Very much appreciate it.
Yeah, thank you for the work that you're doing and pulling together all of these oral interviews and the histories. It's so important.
Thanks, Tom.